Good morning, everyone, and welcome to today's webinar, Pain and MS. Thank you for attending. So in the spirit of reconciliation, MS Plus acknowledges the traditional custodians of country throughout Australia and their connection to land, sea and community. We pay our respect to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. So as I said, our presenter today is Dr. Jamie Young, who is a pain and rehabilitation specialist with many years experience working in acute, chronic and cancer pain. He's currently a specialist at the Peter MacCallum Cancer Centre in Melbourne as the clinical lead of the department and a visiting pain specialist at St Vincent's Private Hospital, Fitzroy in Melbourne as well. His other areas of interest include teaching medical students and trainees, medical leadership and research, and he has ongoing publications in cancer pain, supervision of University of Melbourne research projects, and a supervisor of training at the Peter MacCallum Cancer Centre. He also has a PhD in pain management associated with multiple sclerosis.
Thanks again, Jess, for the invitation and MS Society for this invitation as well. And thank you all for coming today to listen to me talk. I think this topic is really important and certainly holds a special place in my heart due to my experience as a pain specialist, but also with the research that I do and my ongoing involvement in people with multiple sclerosis as well. So I hope you find this informative and happy to take questions as they come at the end at the same time. So what I'll go through today is what we know, what do we do as pain specialists when we see someone with pain and multiple sclerosis. I'll then put that all together through a case and then we can have questions as well. So I'd like to start off with the slide here looking at the mechanisms of pain associated with multiple sclerosis. The very fact with multiple sclerosis that it is a chronic demyelinating neurological condition. So unfortunately it is chronic and therefore demyelinating lesions are involved with the whole process of the development of pain. And as you can see from the slide here, there's multiple mechanisms involved, including inflammation, barrier leakage, changes in the conformation of the central nervous system, and that itself leads to all different sorts of pain syndromes, which I'll go into. The other picture here is a picture of musculoskeletal pain. So it may not be directly related to the multiple sclerosis process itself, pathophysiological mechanism associated with the multiple sclerosis itself, but it may be indirectly affected, such as repetitive strain injuries and musculoskeletal injuries due to changes in disability and impairments that may or may not occur. My next slide here is probably a bit more focused on a broad area of why pain happens and evolves in people with chronic pain syndromes in general. And as doctors and scientists and pain specialists, there is this concept of what we call central and peripheral sensitization on top of whatever pathophysiological mechanism is involved with the initial injury and the pain syndrome itself. So as you can see from the slide here, there's a lot of complicated drawings and neurotransmitters and things, but essentially what it's saying here is that when there's an initial injury and trauma to tissue, the body itself normally forms an alarm system and therefore pain sensors go straight to the brain. However, in the sensitization component, due to ongoing inflammation or multiple tissue injuries that do occur, the body itself and the neuroplasticity that occurs at the level of the spinal cord, at the level of the tissues and at the level of the brain makes significant changes over time. So therefore, after time, the brain itself and the receptors themselves, they become really sensitized, and the alarm system that was supposed to be normal and protective then becomes overprotective. So the alarm system itself becomes over hypersensitized. And that's what we call central and peripheral sensitization. And we think this also occurs in people with pain and multiple sclerosis. On top of this, our understanding of pain now understands that apart from pathophysiological and biomedical components, we know that people are individuals and we come from different backgrounds, cultures, and thinking. And we know that pain can have a significant impact on lots of different areas of our lives. And therefore, this whole sensitization model of pain that we know of can also be affected by other things such as our pain experience, anxiety, how we think. And that actually we know with the limbic system, which is the emotions and memories of things, actually adds to this biomedical model that I'm talking about, and therefore engages and makes this sensitization model ongoing, despite not seeing any tissue damage on what we see in terms of scans and blood tests. So there's lots of classification systems, as I've alluded to before, how complex pain is in patients with multiple sclerosis. And this is also true in other chronic pain syndromes. So we can have acute pain, which is quite new, and chronic pain, which we deem as anything greater than 3 months. And that can be anything. So you can see from the slide here, there's also things like visceral pain, which is things that are inside the body. And that's normally very hard to describe because we don't normally want to know what's actually happening in the body, such as the heart or the stomach itself. And then there's musculoskeletal pain, somatic pain associated with bones and muscles, as well as inflammatory pain and neuropathic pain. And I'll go into a bit about what that is in particular to patients with multiple sclerosis. So as you can see from this slide here, I'm focusing more on this concept of nociceptive pain, which is also normally associated with tissue damage. So that's things like trauma, injuries, inflammation. And in multiple sclerosis, we commonly see musculoskeletal injuries such as back pain, spasticity, and what I mentioned before, such as overuse or repetitive stress on the joints that do occur when our biomechanics change. And that might also be things like osteoarthritis as well. The next slide here shows this tingling picture in the feet, and that's commonly described in patients with MS as neuropathic pain. And we see that in terms of characteristics such as being paroxysmal, which means it just occurs without any particular inciting or event that makes it occur. But there's also this increased sensitivity that I described with this sensitization component. So we feel everything, and that electricity and that burning and tingling just keeps firing despite not actually anything that's touching our limbs. And that's what we call a neuropathic type pain. This is a video clip of a bicycle that a patient that I've known in the past has shown me. And I like this video clip because it just shows that it just shows people who don't have this peripheral neuropathic pain what it is like to feel that way. And what this person is doing is essentially putting some ball bearings or like little balls on the handles of a bar. So when you're riding this bike, you're actually feeling the pain and that different type of feeling that does occur with neuropathic pain on your fingers. So I think that's quite neat what they've shown me here. So other pain syndromes that do occur and traditionally for multiple sclerosis include trigeminal neuralgia. So facial pains are quite common in patients with multiple sclerosis. It's certainly very painful, specifically around the facial area. Peripheral neuropathic pain, which is that example I mentioned before with the fingers and the ball bearings. There's also this concept of the MS hug, which is, we actually think, one of those things where there's the sensitization component occurring, maybe in the actual nerves in the chest area. So you're not supposed to feel your chest. So therefore this hug component where the body is quite sensitized, you actually do feel it. And it's a type of neuropathic pain. And as I mentioned before, not only trigeminal neuralgia and facial pain, but patients can of course get headaches due to the demyelinating lesions that occur and disappear. There's inflammatory pain, as I mentioned before, with neuroinflammation, but also musculoskeletal pain with actual osteoarthritis and changes in mechanics and walking. But also one of the questions I think was brought forward before about non-MS related pain is also can be quite common as well, because patients with multiple sclerosis with different type of impairments therefore can develop increased risk of other chronic pain syndromes, not only just from musculoskeletal injuries, but things like other chronic pain syndromes like fibromyalgia, and I'm sure frequent urinary tract infections from bladder urinary retention, spasticity, can also lead to non-MS related pain. And that's what I mentioned before about widespread pain syndromes as well. So I thought I'd talk about this next slide, specifically chronic pain, mainly because I think chronic pain is a big issue in Australia and definitely in patients with multiple sclerosis, because it is a chronic condition in its own right. And as you can see here, as I've alluded to some of my discussion points before, is that chronic pain affects quite a lot of different people in their lives. And this is 68%, it says here, affecting working age, but also in retirement age, which just shows that it affects a lot of people's working and adult lives. And therefore it has a significant impact and can have a significant impact on depression and anxiety. There's a large healthcare utilization in regards to what is required to help with people with chronic pain, and it impacts those who live in rural but also in the cities as well. And therefore, when you do see a pain management specialist or a specialist who looks at your pain management, I think not only should we be focusing on what the mechanism of your pain is, it's really important to focus on how that pain is impacting our day-to-day life. And I put some pictures here, but things that we should be asking, including our bathing, dressing, transferring, toileting. But not only that, how does that impact our carers and our loved ones, family, our friends? And these are important things because we can actually help with the management of this on top of someone's pain management. And not only that, I think as a pain management specialist, we should be aware of how our mood, anxiety, and also the way we think about pain impacts our pain management as well. And you can see from this image here, there's something called the pain cycle, which is this cycle of ongoing pain. And it's this pain that actually impacts our ability to do physical activity, and therefore that might impact our exercise and deconditioning, and therefore that might impact our relationships, our roles as parents or work, and therefore that actually can feed into our pain, because we actually know there's a bidirectional or fibers that interlink with our pain fibers, our emotion, and as well as our memory that I mentioned as well. And not only that, our physical body in terms of exercise also feeds into that as well. So it's this really complex ball. And that's why I think chronic pain is so difficult to manage in people with multiple sclerosis. And on top of being understanding of someone's day-to-day working and what they need to do, I think it's important that we also know who the person is and look at who they are, what they've been through, what they think of, and where they've been. And this is really important because it helps us understand why we see pain as it is, why we tend to do things in particular when we have pain. So it's not unusual if you do find that your pain management specialist is asking a little bit about who you are. And I think understanding and building that rapport with a patient is really important so that we can help tailor the treatment for you as an individual, because we know that pain isn't just, and a person isn't just one size fits all. So what do we actually know? Well, as I just mentioned before, and with our introduction, that I have looked at lots of literature in regards to multiple sclerosis and pain, and there is some literature on it, but if you really look into it deeply, it wasn't until the 1950s that we began to understand and acknowledge that people with multiple sclerosis had pain. And then it wasn't until the 1960s that there were increasing studies looking at the prevalence, or actually how many people were affected with pain, and if so, what type of pain syndromes. So it wasn't that long ago that we actually didn't think people with multiple sclerosis had pain. And now in the 1990s and 2000s, that's where a lot of the newer work's coming out from, is looking at treatments and actually the different type of pains and what type of medications or non-pharmacological management strategies are helpful for pain. But there's also been updates in terms of how many people actually get pain as well. So if you look at some of the later literature, it can be up to 70% of people who actually experience some type of chronic pain syndrome. So that's quite high. And as I mentioned before, management strategies, it's not one size fits all, and we need this toolbox approach to help with pain management. And I'll go into a few management strategies more in depth, and then we'll talk about larger concepts. But I thought I'd talk first up about pharmacological management, because it's probably one of the most common and first things that people may be exposed to, such as Panadol and Nurofen. So these are what we sometimes call in the medical field as simple analgesia. It's simple purely from the perspective that compared to other analgesic agents that are out there, the easiest to purchase or to use. Panadol specifically, but anti-inflammatories may have an issue if you do take it too long term, and you do need to be careful, especially those with gastrointestinal issues, cardiac issues, as well as hematological issues, mainly because it does impact kidneys as well as a bleeding risk as well. So do be careful if you are going to be taking anti-inflammatories in the long term. Paracetamol has been mainly noted to be one of the safer profiles in regards to a tablet for pain management. But in itself, if you do take it too much or use more than what is suggested, which is 1 gram, which is 2 tablets 4 times a day if it's regular paracetamol, you do run into issues in regards to liver dysfunction. So it's about using these things moderately. If you actually look at the evidence in regards to these type of pain medications for chronic pain specifically, there is limited amount of evidence for it being an effective pain medication. Certainly for acute pain, which is what I do a lot as well in my public work, being at Peter Mac and looking at post-op pain, patients actually do benefit from Panadol, and there is this and Nurofen or other anti-inflammatories such as meloxicam, celecoxib, but it's sometimes this concept about mixing them together might be helpful, and that can be true, and it may actually not be true as well, mainly because we're also understanding more as practitioners this concept of polypharmacy and taking tablets when it's not working. So it's a case-by-case basis and probably needs a lot of reviewing rather than sticking with these medications and not making any changes at all. My next slide is the anti-neuropathic pain medication. So you may or may not be familiar or maybe on these type of medications, but these two are two of the most common type of anti-neuropathic pain medications. So the ones before were also mainly helpful in what I talked about in terms of that nociceptive or inflammatory type pain. These type of pain medications are mainly helpful in neuropathic pain conditions. And these medications, for example, Lyrica, was actually used before for seizures, for epilepsy. And there's this concept where epilepsy and that sensitization issue, excuse me. Yeah, there's this concept where this seizure activity and sensitization issue are actually very similar, because both are where the nervous system is hypersensitized and overreactive. So nowadays, Lyrica is mainly used for nerve pain, and it is on the PBS and subsidized by the government. Amitriptyline was actually previously mainly used for as an antidepressant. Nowadays, at the dose we're using it for neuropathic pain, it isn't as high as the doses we use for depression, but because of the pathways that I mentioned in regards to mood, emotions, and pain, we're now trying to tap into that type of pathway to help with pain. So these medications can be quite helpful specifically for neuropathic pain. My biggest tip with these medications is that they do have their side effects, and they're actually very common. So amitriptyline has dryness of the mouth. Pregabalin and amitriptyline both affect cognition and feeling drowsy and sleepy. And the higher dose you go, the more likely you'll get these side effects. So staying on low dosages, and if you can be more helpful. And you do need to be on them for a period of time, whether a week to a month to a few months. And that is because these are what we call neuromodulators. So just like it takes time for that sensitization to occur, these type of medications do take time in regards to desensitizing and rewinding the body as well. So these are quite unique medications as well. So my next slide are the opioids. So these are, I don't know if you've heard of them, but things like endone, OxyContin, morphine, these are all what we call opioids. So they're from the opium or the poppy seed. And these are what the media or most people talk about as our strongest pain medications. And they're strong because they are opioids, and we use them mainly for acute pain, which is after an operation for a short period of time, and there is an endpoint to these medications. The concern about using these medications in a chronic pain syndrome disorder is the risks and the benefit may outweigh the benefits. And that is because we know opioids in the long term can impact things like our bowels, sleeping, things like sleep apnea, but also needing higher dosages. You can definitely develop a withdrawal symptom if you've been on them for a long time, larger dosages, and then stop taking them. And it can impact bone health and also our hormones at the same time. And the concern has been always that doctors have also done studies on using these medications in chronic pain, and there hasn't been a significant benefit. However, in saying that, I think as a pain specialist, myself in particular, is trying to be more nuanced than just focusing on these studies and listening to patients as well. So I'm very aware that patients may be on these medications, are actually benefiting from these medications, and I'd usually support them in a controlled fashion. It's generally when these medications are used at higher dosages in quick escalation and with side effects that we get concerned. So generally it's anything above 30, 60 milligrams of oral morphine that we get concerned about, because it may impact your ability to use these medications in the future, and the risk of side effects are higher. The other thing is, I don't know if you've noticed it lately, but these are what we call control medications. There's been a lot of focus in media, and I'm sure as a patient, if you've been on these medications, you've also felt that there's a push to get off these medications. There's things like SafeScript, or depending on your state, there's monitoring systems of these medications to prevent doctor shopping. You can only really get 2 weeks supply of these medications as well. And if you go to different doctors getting these medications, that you may be seen as trying to look at getting multiple different doctors in this setting as well. So unfortunately, fortunately, these drugs are controlled, but it is something that we can certainly talk about as a question if you do like, but that's where it's at the moment. So you may also see these two drugs instead. So Polexia or tapentadol and Norsphen or buprenorphine are actually increasingly used as the first line, what we call opioid medications, because these are what we call the newer type ones that aren't pure morphine-based medications. So we try to use the slowest dose possible, the cleanest one possible, and for the shortest period of time. So if you are going to be on opioid-based medication, these two pain medications that are opioid-based may be more helpful as well. But very similar, still 2-week supply, rapid escalation, and big dosages still give you a risk factor in terms of opioid-related side effects. Now, a question that I get commonly asked is in regards to medicinal cannabis. And again, very factual about it from myself and giving you the participants some knowledge about what the medical field thinks about it. Me personally, I have nothing against medicinal cannabis. I think the medical world did feel that medicinal cannabis was pushed out quite quickly, mainly from the perspective that the data and literature focusing on it hasn't been very strong or even present. And that is due to the fact that I mentioned before about opioids being something that as practitioners, we only discovered that it wasn't too effective with lots of side effects. And that's, as a medical field, we're concerned that we're creating another what we call opioid epidemic in regards to the use of these medications. But I'm very aware that patients do benefit from medicinal cannabis. It may have better long-term side effects as opposed to opioids. If you're using it as a small dose infrequently, I would see that as beneficial as well. But it's mainly used for 1, neuropathic pain, and then 2, spasticity. And in fact, spasticity and MS is actually where most of the strong evidence has been in regards to being used for pain. Other things such as for like back pain or for arthritis, probably not as much, but it does have some impact on neuropathic pain, and then bigger impact on spasticity. My main concern with medicinal cannabis is that it's not on the PBS. So at the moment, it's all privately funded. And my concern about that is that trialing that medication and then telling someone that it doesn't work and stopping it may impact their financial status, as opposed to something like pregabalin or gabapentin, which actually might have some impact on spasticity as well, that I mentioned before, even amitriptyline. And we actually know what the long-term effects are, like opioids, whereas with medicinal cannabis, we still don't have strong evidence on what dose is too much and when is it too much as well. Then there's the whole concept of CBD and THC. We tend to now just look at THC and CBD as a ratio. So it's more so the ratio of the component of the medications for pain than just the CBD oil itself. But then again, CBD may be helpful and we just don't have that evidence. So the next picture there is actually an infusion. Commonly, I don't know who's in the audience has experienced it, but some higher order pain management strategies include a ketamine infusion. And that's a nerve pain medication that we actually commonly use in anesthesia, but we give it at low dosages for a few days as an infusion to help people with nerve pain. It's probably something that's not sustainable long-term all the time in short periods of time, but access is also different because hospitals may not be able to have patients in a hospital environment for that long as well. But a ketamine infusion is something that we use as pain management specialists, and using it too much may impact your liver. And again, you may be dependent on it as well. So the common theme here with medications is that you can, what we call, get dependent on it. In other words, needing high dosages, but also or tolerant to it, but dependent on it. So if you stop it straight away, you can also get rebound withdrawal symptoms as well. So therefore, it's important, I think, that we actually look at non-pharmacological approaches to pain management. And non-pharmacological pain management strategies, so that there's not just a reliance on pharmacological strategies, because you tend to get tolerant and dependent on them. And then you'll need higher dosages, or if things don't work. Whereas I find non-pharmacological management strategies don't work maybe initially, but it's actually what will help you potentially in the longer term. And even if it doesn't, I think from the perspective of function, and like I mentioned about impact, it may be helpful. So that's things like mental health, physical health, and our social health as well. So physical activity, some things you might have seen include exercises, and that's probably things like being a independent exercise program, like stretching, walking, Tai Chi. Again, doing anything is good, but not doing too much and not doing too little. And that's where I think a physiotherapist or an exercise physiologist can be helpful. Hydrotherapy, I'm a big fan of, mainly because the heat and the water itself taking pressure off the body help desensitize that type of body. And pacing itself is trying to find that right balance, like I said, between doing too much and too little. Psychological strategies are helpful. As I mentioned, there is this big connection between our emotions, our mood, and also our memory and pain. And there are actually like psychological strategies we do for people with chronic pain and MS, such as meditation, relaxation, motor imagery, which is like imagining us doing something. It sounds quite easy, but it's quite specific. And we also do that for things like people with post-amputation syndromes, distraction strategies, as well as music therapy, which I find really helpful for a lot of our patients, because there's a lot of connections that we do in terms of music and how we feel and how we use it for our pain management as well. So I'd like to finish off with a case. This case is a 45-year-old female who has been diagnosed with relapsing remitting multiple sclerosis for a few years. And this is an example of a patient that I might have seen. And I'd like to give you an example of how what I've been talking about can be helpful in these type of cases. So this patient's currently working in an office, trying to find out a bit about her. She has 2 young children and a husband, so she's very busy. Also plays for her a big role in terms of her work, but also children, and as a wife and as a mother as well. She's otherwise very independent, so she's mobilizing independently as well as independent with her personal cares, but always pushes through her work and taught to work hard. So that's what I mean by knowing a bit about the background. So this patient specifically has grown up in that type of environment, and that's what's important for her. So as I mentioned, she was diagnosed a few years ago. In this case, I commonly do see patients who have neuropathic pain in the fingers and feet, which is a type of peripheral neuropathic pain. It's burning, it's persistent, and in her line of work, which is computer work, it's very annoying because she needs to type. So again, like I mentioned before, she's tried paracetamol and anti-inflammatory and doesn't find that helpful. She sees her general practitioner, and she was started on Lyrica or pregabalin, which is for nerve pain, and she was started on a low dose, 50 milligrams twice a day. So what's low dose? 25 milligrams twice a day is actually the starting dose, but the largest dose is actually 600 milligrams once a day. And the issue again isn't necessarily the dose, but I find that it's the escalation. So commonly I also see patients do come in and they say, I've got pain, and the dose did help initially, but I feel like that I could deal with more. And unfortunately, the dose escalation might be too high, such as going to 150 twice a day. And everyone's different. I'm sure patients have gone from 50 to 150 with no issues, but some patients might find it an issue, and therefore you might get things like dizziness, falls, and sleeping a lot. And that's what happened in this case as well. And as a result, we get this tipsy-turvy. So therefore, this patient becomes so concerned, she stops that medication straight away. As a result, she feels that she's withdrawing from the medication now, so feeling agitated, can't sleep, and increased pain. So instead, she was started on the other pain medication that I mentioned, amitriptyline. This is actually a nice dose to be on, but everyone reacts differently. So for her, she couldn't wake up, late for work, dryness of the mouth, and couldn't look after her kids. So getting increasingly frustrated, and the side effects were actually much worse than actually her pain syndrome that she had. So ongoing pain, wanting more help, and then she was referred to a pain specialist. Now, I think one of the questions was in regards to how to actually see a pain specialist. There are two different types, public and private. It depends on sometimes catchment area, whereas private's less so catchment area. But I think, unfortunately, there is a long wait list to see a pain specialist in the pain management clinic. Mainly because there is a long wait list, and pain specialists are dealing with lots of different type of pain syndromes. So maybe post-surgery, back pain, knee pain, etc. Private, on the other hand, there's probably a quicker waiting list, but you could potentially also get different type of treatments like a ketamine infusion, mainly because private hospitals are actually built to have patients in to have infusions, whereas public hospitals are less so. But this patient got involved with a pain management clinic, and a pain management clinic not only does have a pain specialist, they have specialized physiotherapists, psychologists, and even things like a pain management program, whereby the focus is on impact, function, and teaching pain management skills for the individual. And this patient did. She then underwent Tai Chi, hydrotherapy, and that helped desensitize that body. Education on pain, which is what I talk to everyone today about, but much more in depth. Learned about mindfulness, and then she was actually able to wean off her medications. Although her pain was still present, she was able to do some of the things that she wanted to do. And in fact, some things that we can't always do, so we have to modify. So for her, she took into the point that she needed to reduce some of her work, felt alternative type of work, used her family members, managed her pain better, improvement in well-being, and then there's no long-term side effects and long-term benefits as well. So as I mentioned before, other possibilities that could have been used as a situation included a ketamine infusion. I tend to use them to help reduce medication. So if a patient was on all those medications I mentioned with large doses of opioids still not working, then to try and help people wean off these medications, and infusion is helpful for that type of situation. It's very reasonable to trial other medications. So amitriptyline, there's a cousin called nortriptyline that might have less side effects. And then there's intervention. So if they have non-MS related pain like arthritis, or they have an MS hug, some people may get a nerve block or nerve injection to help, but that might not be long-term, but helpful to break out that cycle I mentioned. And then helpful to engage in non-pharmacological management strategies. So yeah, that's it. Thank you very much. Happy to take any questions.
Great, thank you. One of the questions, Jamie, actually we had was around sort of what is the best management for trigeminal neuralgia?
Yes, trigeminal neuralgia, it's a really tricky pain condition, mainly because it involves the face itself. So it's a very sensitive area. Generally, we try to do what we call conservative management first, which are medications. So most patients have tried things like it's because it's a nerve pain medication, neuropathic pain condition. Generally, most people have tried things like pregabalin, gabapentin, but one of the more common medications specifically for trigeminal neuralgia are things like carbamazepine, which is again an anti-neuropathic pain medication. There's things like Tegretol, sodium valproate, lamotrigine. All these are anti-neuropathic pain medications and anti-epileptic type pain medications. So that may be helpful. If that doesn't work, I think it's reasonable to trial opium-based medication, like that Norseman patch that I mentioned before. And then on top of that, I've used things like ketamine infusion, and I've also organized nerve blocks. So there's a thing called the sphenopalatine nerve block, which is essentially in the face here that you can actually inject some local anesthetic and steroid-based medication. And then there are things like surgery. So some patients have even had their nerve demyelinated or neuralized. And some people have even had MRI scans to look for secondary causes for that trigeminal neuralgia, because it may not be from a plaque, it may be what we see commonly, a blood vessel pressing on that nerve as well. So you can sometimes put a mesh around it as well. So there's a lot of different things you can do. And then on top of that, like I mentioned before, all those non-pharmacological management strategies should always be considered throughout that period of time to help management as well. So I don't necessarily think there's a best way, but I think that there's certainly lots of different ways, and it depends on who you are as the person, what type of mechanism it is, and how significant impact is having you on at the moment. Because based on all that, it can range from trying to manage with tablets and non-pharmacological management strategies to injections and surgeries themselves, which have their risk factors and may or may not be for the long term, and having that repeatedly done may have a significant impact on your health as well.
Great, thank you for that. Another very frequent question that we got asked is sort of being able to differentiate between pain and MS-related pain. For instance, we had someone who had acute appendicitis, and it was sort of put down to being, due to their MS potentially. So that was a really common question about how people differentiate pain.
Yeah, that's a good question as well. I think taking it back a step, I think that's a reflection on us as a medical or even broader wise health professionals, how we actually teach pain. Or not only that, I think maybe even how we talk about pain management and what pain is to society and the community as well. But I think that goes back down to doing a proper assessment and listening to the patient. And it sounds simple that we break it down into, like I mentioned in my talk, this nociceptive inflammatory pain and neuropathic pain. But I think it's generally a mixture. And I agree, I think if a patient does come in with a chronic condition, that when they do go in, professionals may or may not are at risk of particularly focusing on that chronic condition, and therefore putting a lot of emphasis on that condition causing that pain, rather than potentially looking at other causes that may occur. And therefore, I think we're trying our best also to implement proper assessments throughout universities that we're doing in medical schools, to teaching in internship, and through our training to specialists as well. So I think it's really important that we actually investigate, take a proper history and examination, and listen to the patient's concern.
Great, thank you so much for that, Jamie. And we did have a lot of questions today, so anyone that we didn't get to specifically, we'll follow up after the webinar. And so these are just a little bit more information about services that MS Plus offers, and you can get in touch with MS Connect, for any sort of more information. We also have webinars, podcasts, articles, things like that on our resource hub, and this will also be uploaded within the next day or so. And so, yeah, so there are the MS Plus Connect details there for anyone. So thank you so much, Jamie. Really appreciate your time on this. It's a really interesting topic.
All right, thank you. Thanks, Jess.
Thank you.